I agree with you.
Yeah.
Alright, we're going to get started.
All right, arts. Is this one? Sure. Yeah, this will be fun. Okay, I mean, it doesn't matter. All right, so arts. Have you guys, what have you guys, how far into pulmonology are you?
1 week. No, 1 week. 1 week out of 2 weeks.
These are lungs?
There's O2 and CO2.
You done blood gases? Oxygen goes in, CO2 goes out. Surfactant what?
Like soap.
Is like soap. But don't inhale Tide Pods.
Yeah.
Different surfactant, right? So my kids.
Do you have good stories about that?
Oh yeah. My wife's a teacher. Okay, so she's at the Capitol today with my kids.
Yeah.
Yesterday, all right, we're all good. I taught, my wife teaches him. So one of my kids took, I don't eat Tide Pods because my wife's a teacher. I was like, I hope that's not the only reason you don't eat Tide Pods. Great. So they're down at the Capitol today. Yeah, Tide Pods different surfactants, please. You know the new one now, right? The new trend?
Oh, I saw that. Condom.
What?
I haven't seen that one yet.
What? Or something? I saw a picture. And you pull it out of your mouth.
I have not seen that yet.
Don't watch it. It's gross. No.
Why would you ever do that?
Here, we'll Google it.
Don't do it.
Well, I don't get it playing back.
No.
All right. Yeah, I just saw it yesterday.
I know, but it's hard for them to
Well, yeah.
get it. You know,
It is.
I feel like it would be hard.
Yours has more information than this. All right. So yeah, this is a little updated, which is going to be just, yours is going to have more. All right, so here's what you got to do. You got to know what ARDS is. You got to recognize it. Very basic pathology. So the way I think about pathophysiology, when you get out into the world, like your mind's only got so much space, right? Every time you put new stuff in, something's going to come out, right? So like, gosh, the pathophysiology of ARDS, right? I'm so scared that like, I'm going to remember this, and like I'm going to lose something important like my wife's birthday. The pathophysiology of ARDS is not going to save somebody. My wife's birthday might. That's going to save me. So, every year before I get this lecture, I go, okay, I got to remember what this is. So I'm just hoping you learn basically the pathology behind ARDS. You can explain it very simply to somebody. It does involve surfactant, okay? And then, right? Exactly, right? So somebody says, hey, my mom got diagnosed with ARDS. What is that? And you can sit down at Thanksgiving and say, hey, this is basically what it is. It involves surfactant, not Tide Pods. And here's how we treat it, right? This is very simple, all right? So there's a bunch of names for this because we didn't know what it was, and then we put them all together and said, hey, it's ARDS. So the other names are non-cardiogenic pulmonary edema, adult hyaline membrane disease, capillary leak syndrome, or shock lung, which is my favorite. Shock lung. And you got shock lung. So they're all the same thing. This is all ARDS. And it's actually kind of a spectrum from what we call acute lung injury to ARDS. So it's all kind of a spectrum. But the definition is this. It's acute. It's right there in the name, right? Acute respiratory distress syndrome. Adult respiratory. Acute respiratory distress syndrome. It's bilateral, okay? So it's not one-sided. This isn't like an empyema. This isn't like a pulmonary effusion or a pulmonary contusion. This is bilateral. And it's not due to cor pulmonale. It's not due to your heart, okay? So this is not due to heart failure. This isn't pulmonary edema coming from the heart. All right, this is completely independent of the heart. This is a good, usually good working heart. All right, this is a person who's got a good EF. They might not have a great EF, but this is not because of cardiogenic shock. This is not due to fluid overload. This is not due to left heart failure pushing back into the lungs, okay? So we have an acute, bilateral, non-cardiogenic problem. Hence the idea that it's non-cardiogenic pulmonary edema, right? Okay, so just remember one of these names that we got. Okay. All right, and again, this is a spectrum of disease. It starts with acute lung injury, and it goes all the way up to ARDS, acute respiratory distress syndrome. And it just depends on how hypoxic you are. Now there's ways to measure it, and I think in your old one, I gave you all that stuff, and if you memorize it, you're going to forget something important, and that's on you. So, and it has to do with their FiO2 and the ratio of FiO2 to SaO2 and all this kind of stuff. It doesn't matter, okay? We don't do that in real life. You're not going to go measure all that. You're not going to drop swan gans in them. You're not. If they have bilateral opacities and they're full of fluid, they're going to have ARDS, okay? And the worse it is, it's just worse. So we don't call it ALI and all this stuff. We don't measure all that. They have ARDS, okay? You just need to know it's kind of the spectrum. So what's it look like? This is ARDS. Bilateral, fluffy lungs, okay? Bilateral, fluffy lungs. And you can see, this heart's not very big, if you guys have learned to read radiographs at all. That's not a very big heart. This person's not. This is not a cardiomegaly. This is not a huge heart. This is a bilateral pulmonary edema. Okay? Here, I made some more pictures for you. I drew these for you. They're black and white, I'm sorry. So, bilateral, top to bottom, pulmonary edema. Throughout the lungs, right? This isn't just left side, this is right side, this isn't just apical, this isn't basilar, this is throughout the lungs. Okay? If you see a kid, same thing. This is spread throughout the lungs, it's bilateral, it's not caused by congenital heart defect, it's not caused by fluid overload. This is an acute lung disease. Okay? I thought I did pretty good, my etch sketch. All right. Again, because I have to, you got to know this, probably. It's rare, but unheard of. 60 per 10,000 patients. Okay? Per 10,000 people. However, 20% of people admitted to the ICU will meet the criteria for ARDS. They will have bilateral pulmonary edema not attributed to cardiogenic cause on radiographic x-rays, on radiographic studies. All right, so it's, in the ICU, it's pretty decent. Mortality, once you're diagnosed with ARDS, is up to 40%. Now, of those, 80% of the deaths are non-pulmonary, other than lung organ failure. We'll talk a little bit about that in a second. So once you get ARDS, you get a lot of other problems after that, too. And of course, the risk factors are the same as everything else. Age, other problems, liver failure, kidney failure, metabolic problems like diabetes, things like that. Patients with ARDS from a direct lung injury have a higher incidence of death than from a non-pulmonary injury. Okay, we'll get to this right now, right? So, what does that mean? Okay. You can get ARDS from a bunch of things. The most common is pneumonia. So you get pneumonia, then you get ARDS on top of it. You get a superimposed ARDS on top of it. However, there's plenty of other causes, such as drowning. You get water in your lungs, and then superimpose on that, you get ARDS on top of that. The second most common, though, like I said, in ICU, is you get septic. So from whatever, urinary, cellulitis, whatever it is, endocarditis, whatever it is. And after that, you get ARDS. But there's a bunch of them, right? You get you aspirate, you're older and you aspirate, or you because trauma. But as I said in the last slide, patients with a direct lung injury, so pneumonia, drowning, aspiration, trauma to the lungs, so pulmonary contusion like that. If you enter into ARDS from a direct pulmonary insult, you have a higher risk of dying than from these other things like sepsis or all these other ones. And you'll see why here in a second. All right, so here's the pathophysiology. There's a direct or indirect injury. This is the alveolus, right? There's a direct or indirect injury.
We have a steak.
All right. How hard is it to replace? Okay. So you got it. You got the alveolus. Pretty good stick to have. What do you sit in the front row? Usually the second row. It's pretty dangerous. So you have the alveolus. This is a normal one, right? Surfactant layer intact. There is some kind of direct injury to it. Once you have the injury, you have the inflammatory response. So you get all of these pro-inflammatory cytokines. You get the leukotrienes, the neutrophils, the macrophages, the interleukins, the TNF organisms. You get all of these pro-inflammatory cytokines that rush in to take care of whatever insult there was, right? To try and bind up and take care of all of this. It becomes all this junk that happens in the alveolus to take care of whatever the insult was. This is that insult down here, this cellular debris stuff. Now, once that happens, so it attracts all of this stuff in your system, it damages this layer, this alveolar capillary membrane, right? This basement membrane, the alveolar capillary membrane. Once this integrity is lost, the alveolus begins to flood with proteinaceous, this thick kind of proteinaceous fluid as it comes in. The surfactant can no longer keep out this fluid, this interstitial edematous fluid that's collected here. And you get this proteinaceous fluid coming in. All right. So simply, this is the part that you get to tell your friends. The alveolus gets inflamed due to some kind of insult. Aspiration, pneumonia, drowning, whatever. Its membrane loses its integrity, and that alveolus then gets filled up with this proteinaceous thick fluid. Once it gets filled up with thick fluid, you have a boggy alveolus that can't participate in oxygen exchange. It can't take oxygen in anymore. It's now a fluid-filled alveolus and no longer an oxygen-filled alveolus. Okay? So you can see why in the flu, it often leads to ARDS in healthy people. They have an excellent cytokine response here. Overly excited response, which causes this massive leak of proteinaceous fluid into the alveolus, leading to ARDS. So these healthy people get ARDS more often than elderly people with the flu. All right. Now, once you get ARDS, you get all kinds of problems. What's VQ? Why is Q perfusion? Stupidest thing ever. All right. So ventilation makes sense, right? I mean, that's a V. I don't know why Q is perfusion. Why Why is tungsten W on the periodic table?
Because it's Latin word started with a W.
Close.
Same as gold and like. Silver.
Close.
Greek. It's Greek.
No.
It's dead language word.
German. Wolfram. Tungsten. Wolfram. I don't know why Q is that, but it's okay. Okay. So you gotta know history and stuff too. All right. So you get a VQ mismatch because of shunting, right? You guys learned shunting yet? It's okay to say no. All right. So this is shunting, right? You get an alveolus that is full of junk, whether it's pneumonia or ARDS. It can't participate in oxygen exchange. So what you get is perfusion. You get blood going past. You get a perfusion, but no oxygenation. So this is deoxygenated blood. This is unoxygenated, deoxygenated blood. It's not picking up any oxygen. This is oxygenated blood. It's picking up oxygen. What you get is mixed blood. Half unoxygenated, half oxygenated. So this is called shunt. This is a shunt. Past unoxygenated or past deoxygenated alveolus. Okay, this can happen in the baby. This can happen in pneumonia. This can happen in ARDS. So you get perfusion without ventilation. Even if I jack up to 100% oxygen, put this person on 100% oxygen, it's not going to help. Because there's no oxygen exchange happening here. They're not going to get any oxygen. It's just not going to go into the blood. Okay? So this is shunting, and this is one of the problems with ARDS. It also happens in CHF, when you have pulmonary edema. Okay? Now eventually, the body will fix this. It will actually constrict this vessel and limit the blood flow past here. It takes hours, though, for the body to catch up and constrict this vessel and to give this preference over here so that you don't have as much mixed blood through here. So one of the biggest problems in ARDS is this shunting effect. All right. The second problem is, so this is the impaired gas exchange, this impaired oxygenation. It's a decreased ventilation, right? So oxygenation is getting blood, or getting oxygen into the blood. Ventilation is getting oxygen into the body, right? The breathing part. If you've got all these alveoli filled with this proteinaceous, thick fluid, and you try and breathe, it's very hard. The lungs get boggy and stiff, and it becomes very hard to breathe. So this is one of the hallmarks of ARDS, are these stiff, boggy, difficult to aerate, difficult to ventilate lungs. Now you can imagine, the third problem is, if you have a heart that continues to try and pump against this, what happens to the right side of the heart and the right side of the circulation after a while? Yeah, exactly. So these are the three main sequelae of ARDS. Poor oxygenation, poor ventilation, and then poor circulation. Okay? These are the three main problems you have to treat. Okay? All because those little alveoli get full of this proteinaceous material. This proteinaceous fluid. So what's it kind of look like? Well, I'm not going to show you. Just kidding. All right, so what do? You treat the underlying cause, you treat the underlying cause, you treat the underlying cause. Remember, ARDS doesn't happen by itself. ARDS happen because of something. Those little alveoli didn't fill up on their own. Something happened to make those alveoli fill up. So we treat the underlying cause, and then we support the patient, usually with mechanical ventilation. Sometimes with non-invasive mechanical ventilation, which means what? What? Mask or
Intubation.
the cannula. What else? Non-invasive. Nobody uses non-invasive ventilation at home? CPAP or BiPAP, right? That's non-invasive ventilation. Or we invasively ventilate them, put a tube in them, okay? They've already got plenty of fluid, so let's not give them too much more, okay? All right. So there's 4 good studies. So there's a group called ARDSnet. They looked at the problem of ARDS. Go figure, ARDSnet. And they came up with 4 groundbreaking things. This all came out about 10 years ago, no, 15 years ago now. All right, the first thing they said was, we used to give everybody 10 cc's per kilogram of ideal body weight per breath when we ventilated them. So ideal body weight. Remember, Oklahoma people, not actual body weight. Do our lungs change with our weight? No. Our lungs change only with our height, not with our weight. So a 400-pound person who's 6 foot and a 200-pound person who's 6 foot have the same lung capacity. If they're the same sex, male and female. Change with your sex too. They get ventilated the same, okay? The same volume. If you try to give a 400-pound person the volume for his weight, you're going to blow his lungs out. He's going to be this, you're going to make him a hot air balloon. His lungs are the same size based on his volume is based on his height, not his girth. Okay? So remember, all ventilation happens based on ideal body weight. All right? So originally, we've always given people 10 to 12 mLs per kilogram of ideal body weight. Every breath we give them, if you were 100 kilograms, you got 1 liter per breath. 1 liter of air in, relax. 1 liter of air in, relax. 1 liter, every time we gave you a breath. That's what we always did. Then ARDSNet came out and said, no, that's way too much. You're giving people way too much because half their lung's not doing anything. Half their lung is underwater. That's way too much. They said, cut it down to half. 4 to 6. Okay? And by doing that, we reduced the mortality, we got them off the ventilator quicker, we decreased all the other problems, these other extra pulmonary problems, right? So when you stop blowing up their chest, what happens when you increase the pressure in your chest?
Volume goes down.
Okay, what volume goes down? The volume. What volume? The what? Intrathoracic pressure, right? So what else goes down? Or what goes up? Not the pressure. The pressure went up. The pressure goes down. Well, okay. So if the intrathoracic pressure goes down, what goes up? If the intrathoracic pressure goes down, intraplural, that's horrible. Please don't make that go up. Then you get a pneumothorax. Okay? Right? Your venous return. Right? So if your intrathoracic pressure goes up, you're limiting your venous return, right? You're putting pressure on your venous return and it keeps your venous return down. So as you lower your intrathoracic pressure, your venous return goes up. And your blood pressure will go up, right? Because you have better return, better venous return, better circulation. If you increase your intrathoracic pressure, you're reducing your venous return. Okay, it's harder for your blood to get back to your heart. So if you can lower your intrathoracic pressure, your heart has an easier time returning the blood and circulating the blood. So hey, man, if we, let's see if I can, please, oh, okay, here it is, good. So this is what an ARDS looks like, ARDS patient looks like. They have 3 areas. They have a damaged area of alveoli. That is worthless. It cannot participate. Those alveoli cannot expand. They can't collapse. You have an area that's kind of okay. They could probably, if you gave a little pressure, could probably push that fluid out and participate. Then you've got good lung at the top. That can participate. So people have never really looked at this. We were giving people 12 cc's. But all we were doing was putting all 12 cc's per kilogram in this good lung. Okay? So what happens is it puts pressure on these central structures, like the vena cava. If you put it on the vena cava, the body can't return that. So we said, okay, let's cut that down. Let's really just try and inflate this part of the lung. We can. Now we reduce the intrathoracic pressure and we allow blood return. Hey, now everybody has blood return. We can move the blood around. We don't blow out this part of the lung. We don't blow out all the good alveoli. We recruit these kind of alveoli, and we allow these to heal. So by lowering the pressure in half, we took care of the lung, helped the circulation, reduced mortality, and got people off the ventilator. Okay? Just by taking it. We never really looked at this that way. We just kept giving people air. They don't have air, give them air. Well, this doesn't need air. It can't participate in oxygen exchange anyway. All right, yeah.
So by doing this, like you said, just recap, you're going to allow the alveoli to actually heal the ones that are collapsed.
Correct.
Okay.
And we'll get to that in the next two steps,
Okay.
how it helps. Okay? But the first thing is we have to, we take it down to 4 to 6 cc's instead of 12. We aerate this lung, and the idea is we're going to use PEEP. We talked about PEEP at all? You guys know PEEP? Positive end expiratory pressure. Okay? So the end expiratory pressure, this is what's left in your lung after you breathe out. When you're finished breathing out, the pressure in the airway when you're done breathing out. What's the pressure right there? Okay? You can increase your PEEP. So if you've ever seen an asthmatic or COPDer who is pursed lip breathing, what they're doing is they're increasing their PEEP because they're putting pressure. By creating that little tight window, they're actually making back pressure in their lung. By pushing against something, they're actually putting pressure back in their lung and pushing the alveoli open. Mountain climbers do it when they're at high altitude. They do what's called step breath. They take a breath every time they step through pursed lips to keep those alveoli open. CPAP and BiPAP do the same thing. While you're breathing, they push air into you to keep those little alveoli open. PEEP does the same thing. When you breathe out, it actually breathes in a little bit and pushes pressure in against you to keep the alveoli open. Hopefully I've got it. Yes. Here's PEEP. Thank you. Yes. Okay. Here's PEEP. Okay. We'll start with no PEEP. So you breathe out, you breathe in, you breathe out. There's no PEEP there whatsoever. You breathe out, you breathe in, you breathe out. That's your lung. There's no back PEEP. Now we add PEEP, just a little bit of PEEP. Now we add more PEEP. We keep PEEP. This is 5 centimeters of PEEP. Now all those little alveoli are staying recruited. Now every alveoli is keeping open and staying open between breaths. Okay? So as long as you have a little bit of PEEP, those alveoli are staying open. Now the minute you take away PEEP, it collapses. What's the hardest breath you ever take?
Your last.
Trust me, that's easy. Your first one is a baby. Your very first one, where you have to open up those alveoli. Where you have to open them all up. Where you have to break all that surfactant and open up those alveoli. Okay? So, have you ever tried to blow up a balloon? That first breath, when you first open the balloon up, that's it. So what we don't want to do is have to do that every time you breathe. We don't want to open a balloon and then shut it. And then open a balloon and shut it. We want to open it and keep it open a little bit. Okay, and that's what PEEP does. It keeps the alveoli, what we call stented, or open a little bit. Okay, so that's what PEEP does for us. And all right, that's what PEEP does. So what we're going to do is we're going to give them a lower volume, but we're going to add some PEEP. So we're going to keep these alveoli open and try and push these open and use a little bit of pressure. So if the alveolus has a little bit of fluid in it, if we put a little bit of PEEP in here, we're going to try and push this fluid back in to the capillary. Now if it's completely full, there's no amount of PEEP that's going to push that out. But those middle zone ones, if we add a little bit of PEEP, the idea is that we can push that out a little bit. Okay? So, what we don't want to do is, these are susceptible to damage from opening and closing. We want to keep these stented open with a little bit of PEEP. Just a little bit. All right. On the way home, put your head out the window as you drive home. That's like PEEP. Like a dog. All right. So, that's the first thing. Low tidal volumes. So then, they said, if you give people low tidal volumes, how about if we up their PEEP? Will it do better? And they found out, yes, it does. Every ARDS patient needs some PEEP. It keeps that fluid out, it keeps the alveolus a little bit open, and it maximizes recruitment. So you saw recruitment there. A few alveoluses, then the next ones, then the next ones. That's recruitment. When you start bringing your neighbor in to oxygenation, that's stenting. And it stops that recruitment of, that cycle of recruitment, de-recruitment, recruitment, de-recruitment. So, give them PEEP. All right. Two things. So we're going to aim PEEP to increase recruitment without hyperinflation. We don't want to blow these things up. You don't want to overblow the balloon. Then you get a face full of balloon. All right, so some moderate PEEP, 5 to 10 centimeters of H2O. Okay, and then we're going to talk about plateau pressures and peak pressures next. Okay. All right, there's PEEP. All right, so you have these pressures in your lung, in your whole system, right? I'm not an artist. Couldn't tell already. That's not going to work. I called the principal's office once when I was teaching because I made an obscene drawing on the board accident. Didn't even know it until my kids said, I had no idea. So I'm not trying to be better. All right, we have a lung. Here we go. Lung and a trachea and a mouth. Let's just keep it easy. I'm not going to try to draw a face and all that. All right. So, and then we have little, here, an alveolus. All right. Everything's to scale.
A bleb.
Right? Everything's to scale. So, there is a peak pressure and there's a plateau pressure. When you take a breath in, or when you were given a breath, you hit a peak inspiratory pressure. That peak pressure measures the amount of force it takes to get a breath all the way down to here. The plateau pressure is the amount of pressure on the alveolus down here at the alveolar wall when you're kind of holding your breath. Now, there are a lot of little airways right in here. Sometimes it's hard to get a breath, like an asthmatic or a person with COPD. And it takes a lot of pressure to get a breath in. And so the peak pressure to push a breath in is very high, right? They got a lot of stenosis, they got a lot of mucus, they've got a lot of constriction. But the alveolus is wide open down here. So the peak pressure is high. There's a lot of constriction or whatever else up here. But once they get the breath in, it's not very high. The plateau pressure. Once they get the breath in, it's not too bad. So in someone who's asthmatic, you might have a very high peak pressure, but then a nice plateau pressure. Our peak pressure, we want it to be less than 40. Okay? Otherwise, you have a real problem. They need bronchodilators. They need something else. Your plateau pressure, you want to be less than 30. If once you exceed 30, you're blowing out the alveoli. Okay? So that's what ARDSNet looked at, was finding a way to keep this under 40 and this under 30, and then keeping a peak of like 5, so that it's always open a little bit. We're going to talk a little bit more about that in the bit lecture part. So, yeah, so they wanted to reach a plateau pressure between 25 and 30, and never trying to always keep below 30. All right. So then the last part, right? So low tidal volumes, increase the PEEP so we get all the little alveolus working for us, and we push out some of that fluid. And then, because fluid's a big problem, start to diurese them, right? So if they're shocky, give them fluids, but once you've got them over the shock, start to diurese them and take the fluids off. And this is where we start to get those ones that weren't involved, that lower zone. That's where we get those lower zone alveoli start becoming respiratory. So get that fluid off of them. All right. So diurese them, aggressive diuresis. Once they're past the shock stage, so if they're septic or they have pneumonia or whatever, once you get it past the shock stage, you've given them appropriate fluid, begin to diurese them and get that fluid off of them. Then they did a really cool study, which said, what if you changed where that fluid was? What if that fluid wasn't always in the lower zones? What if it wasn't always in the dependent back part of their lungs? What if you flip them over every couple hours? Well, it really worked. It significantly decreased the mortality. So we have these beds that actually rotate patients every couple hours. They actually put them in beds, and this bed will rotate them. Or the nurses rotate them every couple hours in swimming positions to change the location of that fluid. And it significantly decreased their mortality and decreased the number of days in the ICU by changing where that fluid is, by creating new areas of open alveoli. So get the fluid off of them and then change where the fluid is. So they are making newer and newer beds that automatically do this to patients, that rotate them every hour in the bed without the nurse having to do anything. It's really quite cool. Because you can imagine what a bear this is with all these lines and tubes and everything else to do that. So they're making these now on their own to do this. Yeah. So prone positioning, changing it every couple hours to rotate where that zone of fluid is. So those are the four things, right? So summary, recognize it early, right? Acute, bilateral, non-cardiogenic pulmonary edema. Intervene in the disease process. If they have pneumonia, treat the pneumonia. If they aspirate, if they overdosed on Tylenol, they overdose on aspirin. Aspirin's a huge problem with lung injury. If they have sepsis from some other cause, intervene in it. Whatever the cause is, intervene in the disease process first. Intubate or provide positive pressure, CPAP or BiPAP. And do so at a low tidal volume so that you are oxygenating the areas that need oxygen, but you're not over-distending the lungs. You're allowing the heart to continue to work without stressing the heart out. You're not increasing that intrathoracic pressure. Give them PEEP so that every alveolus that can work. Recruit all those extra alveoluses. Push out as much fluid as you can, but don't harm those dead ones. Diurese them early and flip them around to change where that fluid is. They don't have to be 100% on oxygen. You don't need to be 100% oxygen. 88 to 92% is our goal of these people. Hyperoxidation is bad, right? We know that. Hyperoxidation causes free radical, causes all kinds of problems. So 88 to 92% is fine. We don't have to get these people up to 100%. Okay, so ours is not really difficult, but it does have a very high mortality if you don't intervene early, if you don't treat these people very seriously. And if we do things the way we've always done, our mortality will stay at 40%. So I think we're doing things much, much better. We're doing things a lot faster these days. We're getting intubated quicker and being aggressive about it. I used to always put people at 10 to 12 cc's per kilogram. I don't put anybody. Everybody now gets 6 to 8 cc's per kilogram. Even if they're just not ours, I just do it now. And they're fine. It's standard now. All our RT, our respiratory therapists, nobody goes above 10 cc's. Everybody gets down at 6 to 8. It's because we don't want to cause any problems. I think it's standard now. I think there's even an ARDSNet table now that spells out all the PEEPs and FiO2s and all this stuff. ARDSNet put it out. We follow it pretty religiously. Yep.
What did you say about aspirin?
Yeah, aspirin is notorious for causing lung injury, acute lung injury. It causes a terrible metabolic acidosis and respiratory alkalosis. And it's notorious for causing a direct acute lung injury. So I mentioned it in that little pie graph. You'll see overdose. Aspirin is the overdose that's known for that. It's really bad for it. The other one that's in general, so in our history we've always given activated charcoal for overdoses. It's probably not a good idea. It doesn't really do much. It's another thing. Toxicologists will tell you don't do it anymore. But activated charcoal is unbelievably toxic to the lung. So what you have these people that have overdosed, they're maybe kind of slightly obtunded, they vomit and aspirate. And activated charcoal is the worst thing in the world for the lung. It is like lung killer. And so you'll have these patients up there that have aspirated charcoal, and it looks, I mean, it is ARDS, like it is horrible. So overdoses who aspirate charcoal, it's just horrible, horrible. Yeah?
When you're moving the patients around to move the fluid, would the movement of fluid to otherwise healthy alveoli cause any risks?
It doesn't tend to. It actually tends to help.
Okay.
Yeah, it doesn't tend to. And so they looked at that. That was a big part of that paper, that ARDSNet paper, was, are you hurting good alveoli in doing this? And they don't. So that's why they do it like every hour,
Yeah.
is to not cause that disruption of that basement membrane. They tend to do it pretty regularly.
Yeah.
Yeah, it's a good question. It's all covered in the paper. Anything else? ARDS, not too difficult, really. It sounds worse than it is worse, but I mean, it sounds more daunting. Anything else on ARDS?
Do you vent no matter what?
No, so we've kind of gotten away from it a little bit. I mean, we vent most people, but the BiPAP and CPAP have helped us a lot. We also have something called high flow nasal cannula now, Vapox and all these things that we use a lot more now to kind of bridge them. So, like I said, there's that spectrum of acute lung injury down to ARDS. And so we're intervening. We're beginning to say, hey, it's a spectrum. So if we can intervene at the acute lung injury part, where we're beginning to see kind of fluffy lungs and they're not CHF, if we can intervene there and put them on high flow nasal oxygen, BiPAP, CPAP early, we find that 8, 12, 24 hours of CPAP saves them from a ventilator. And if we can save them from a ventilator, man, the risks of a ventilator are huge, right? Some people don't come off it, you get secondary problems. Anything else? Okay. The ventilator. All right, so you got ABGs, this is good. Is there some questions? They're actually updated this one a little bit, so I'm going to actually move over to a different one here. Because I did update this one. Nope, that's the same one. We're going to do ARDS again. Just for review, it's so important. Okay, so ventilator, if you do any critical care, emergency medicine, you'll do it. If you do internal medicine in the hospital, you'll probably do a little bit of it on the wards. I love ventilator. It's so much fun, but it can be very intimidating because there's all these dials and buttons and alarms and beeps and bells, but it's really fun. Okay. All right, so why do we intubate people? Oh, that first picture you missed. Yeah, look. That's it's through his, yeah. There's a good story about that. Isn't that great? Yeah, he did fine. So obviously intubation is the process of putting a plastic tube down somebody's trachea through the true vocal cords into their trachea and breathing for them, putting them onto a ventilator, right? The process of intubation. We typically do it with sedatives, so they are asleep, and paralytics, so they are paralyzed. Typically, that's ideal. That's the ideal way to do it. Doesn't always happen that way. That's ideal. We do it for these three reasons. Airway protection. That would be the case of the guy on the top right. All right? He is going to develop some real swelling of his airway. He's not going to breathe very well after this. I don't want him sitting around in my emergency department like this, because he's going to start occluding his airway. It's better to intervene quickly on this gentleman. So trauma, head injuries where a person's kind of obtunded and they have problems swallowing. So we used to say GCS less than 8, intubate. So the person's not following you well and they could start vomiting and aspirate. or just, having problems with their gag reflex and things like that, intubate them to protect the airway. You take over the airway. Before a surgical procedure, obviously, so you guys had surgery, we intubate, right, during your surgical procedure. Anaphylaxis, about 2 weeks ago. So 16 years I've been doing this. I've seen plenty of anaphylaxis, and I've only done 2 brachydothyrotomies, cut-downs. I did 1 my first year. I did 1 2 weeks ago. And I mean, it's not like quite like on TV where you do them on the plane. You do them in Korea. And we tried to intubate her traditionally through the mouth, and she was so swollen. She just came in 10 minutes earlier eating some peaches that she was allergic to. She came in, she couldn't talk, she couldn't breathe. And we tried to intubate her, and we couldn't. We had to cut her neck open. So, airway protection. Protect your airway. So, second one is difficulty oxygenating. So if they're having problems breathing. So this is the ARDS patient we talked about. Severe pneumonia, drowning, things like that. Or difficulty with respiration. So if they're having problems breathing, this is actually moving air. So this is someone who's in severe sepsis, has been sick for days. Someone with like Guillain-Barré, who's becoming paralyzed, their diaphragm's becoming paralyzed, and they just can't breathe. It's not an issue of oxygen, their alveoli are open, they're not moving air, they're simply not moving. Myasthenia gravis crisis, things like that. All right, little pediatric kiddos with RSV who've completely worn out, they've been sick for 3 days, and they're just so tired they can't breathe anymore. So those are the 3 reasons we intubate people. All right, so ventilator, my favorite movie, right? A ventilator is just a big bellows, right? You're just pushing air into somebody. You can do it faster, you can do it harder, really hard, or you can do it deeper, big breaths at a time, right? That's all it is. That's all a ventilator is. If you remember that, it's simple. Is you can do it faster, harder, or deeper, big breaths, okay? And that's all a ventilator is. It gives you an amount of air over an amount of time at a certain pressure. That's all a ventilator is. So whether you're doing it for true love, as Mad Max is, or to bluff. To bluff. Okay, so it's a bellows. You guys hopefully all know these little terminologies, right? Okay. Yeah. Tidal volume, minute ventilation, all those kind of things. All right, good. All right. So we think about the T's, and that is what triggers the ventilation and what's your target. The other 2 T's are timing and termination. We can talk about those a little bit, but there's 4 T's really, but we're going to talk about the 2 T's, trigger and target. We're going to talk about timing, it's kind of built in, and termination is kind of built into it fancy. Okay, who triggers the vent? Do you, as the provider, or does the machine trigger the vent? That's the first one. So a patient who's obtunded or confused, who can't breathe well, do you let the machine take over and breathe for them? Or is this a patient who's awake, like the anaphylactic patient who's awake, but who just can't breathe, whose airway is totally occluded? Do you let them breathe for themselves? Or you just have a piece of plastic in there for them to breathe through, and you let them breathe on their own? So, is the patient breathing, or is the machine breathing? Who's doing the breathing? Who triggers the breath? I was going to spread the food. Okay, there's 3 kinds of settings you can turn on. The main dial has 3 settings: AC, SIMV, or pressure control. The majority of the time will be AC. That's assist control. That means you, as a provider, have complete control. The ventilator, the machine, has complete control. The patient does absolutely nothing. You make all the decisions. You are assisting and have complete control. If you want to share the control, it's SIMV, synchronized, intermittent, mandatory ventilation. Its control is shared. If the patient's going to do the work, it's pressure control, pressure support. We'll talk about these. So first is assist control. The machine will breathe, and the person does nothing. The machine doesn't sense the person breathing. It doesn't care if the person breathes. It's going to keep breathing at the rate and volume and time and pressure you tell it to, no matter what. If you tell it to breathe 50 times a minute, it's going to breathe 50 times a minute. It doesn't matter if the patient gets very alkaline. If you tell it to breathe 4 times a minute, it doesn't matter if the patient gets very acidic. It's just going to keep doing it. If you tell it to breathe at 1.5 liters per breath, it doesn't care if the patient's lungs explode. It's just going to keep doing it. It's just a machine. It's a big, dumb machine. It might sound off bells, and everybody in the hospital is going to hear it, but it's just going to keep doing it. So, you've got to be careful when you make segments. Okay? If it's on SIMV, this is a little smarter thing. So you put the tube in, you hook up these little tubes that go back to the machine. And in it is this very thin little tube. It goes back to the machine. Oxygen goes through the tube back to the machine, constantly in a circuit. And in this little tube, the machine can tell when the patient breathes in. When there's a negative flow, that machine knows, the ventilator knows. It has a negative loop in it. You set the machine for 12 breaths per minute. You set the machine for 12 breaths a minute. If the patient is breathing at 12 breaths a minute, the machine does nothing. It does absolutely nothing. If it senses the patient's breathing 12 times a minute, the machine does nothing. If the patient doesn't breathe every 5 seconds, the machine will give a breath. So it helps the patient. If it's 4 seconds the patient breathes, or 4.5 seconds the patient breathes, but doesn't take a good breath, the machine will give the patient a little more. Because you've told it, hey, this patient needs 800 cc's of air. And the patient kind of goes, huh. Then that patient, it'll give it a little extra. So it's teaming up with the patient. Okay? So this is why it's synchronized with the patient. Intermittent, mandatory ventilation. That patient will mandatorily get ventilated 12 times a minute at a certain volume. Okay? Which is nice, right? So it's a good compromise. The pressure-controlled pressure support mode has no control, well, it has control for you, but it's all dependent on the patient. All you do is specify the pressure you want, how much pressure you want given to the patient. When the patient breathes on their own, the machine then gives them some extra pressure, helps them take a breath. So if the patient's not breathing very good, the machine just kind of goes, and gives them an extra breath. Like, woo, that was fun. So the minute they start breathing in, the machine senses it and just gives them the rest of the breath. Patient doesn't breathe, the machine doesn't give them a breath. So what you do is you set an apnea time on it, which is a new thing in the past 15 years. We didn't have this. If they don't breathe in 60 seconds, give them a breath, please. It didn't used to happen. So, this is completely set by the patient though. If they're not breathing, they don't get a breath. You just specify how much pressure. Now we know all the laws, right? So pressure, time over pressure, volume. You can figure out how much volume they're going to get by how much pressure they're getting over how much time. All right, so the target, I'm telling you, it's just a bellows. I think we can stand there and do that if we really want. We do that in the back, right? Okay, so assist control and synchronized control, you set the pressure, right? The patient begins to breathe, they get some more. But with assist control, you can also set the volume, which is important. And that's what we want, right? For like ARDSNet, we want 4 cc's to 6 cc's of volume. That's really important. And we want to measure that plateau pressure we talked about, the peak plateau pressure. We want to keep the plateau, or the peak below 40, ideally below 35, but below 40. We want to measure that plateau pressure below 30. And we can set those in all these modes. All right. So this is just an example of the same thing you see. This is normal. You take a breath, you have a peak pressure, and then it relaxes, and that's the measure at the alveolus. This is a person with asthma. High peak pressure, and then a normal plateau pressure. This is a patient with ARDS, high peak pressure and high plateau pressure. So the stiff, boggy lungs. Okay. So all of a sudden the alarms start going off and telling you your pressures are way too high. Way too high pressures. So you got to think the man versus the machine. You've got a machine pushing air into your lungs. Either the machine is messed up, you got the wrong settings on it, and you're trying to push way too much pressure in. Or the person, so normally we paralyze the people, or we sedate them a lot when we put them on these machines. Maybe they're trying to breathe against the machine. So they're trying to breathe out when the machine's trying to breathe in on AC. Or they're trying to breathe way too fast. That's going to cause a pressure problem. So the first problem could be the machine is set wrong. Maybe you've got a kink in the hose, right? When you turn the hose on in water and you kink the hose, you turn the water. Same thing happens in the vent circuit. The little tube that's carrying oxygen. You've got a kink in the hose, and the machine's trying to push against it. And it gives you this horrible pressure reading. And the machine's going off, and all the nurses are looking at you to solve the problem. Well, just straighten out the hose. Maybe there's a bunch of mucus. You started coughing, and it came up the tube, and there's a big ball of mucus in the tube. There's a little filter on it. Maybe the filter's just gotten soaked from him coughing or from his just breathing. Maybe it came loose. The circuit came loose. These are all machine problems. These first two things are all machine problems. So if your peak pressure is 60 or 50, look at the machine. Is the machine set right? Is the machine okay? Is everything in the circuit okay? And then look at the man. Are they just super tight like any asthmatic? Does he need bronchodilators? Are they like ours? Is it just bad, boggy lungs? Do they need more diuretics? Do they need a lower pressure? Do you need to lower the pressure even more? Do they have a pneumothorax? You need to put a needle in them or a chest tube in them. Is this person weighs 600 pounds, their belly's way up here, and they just can't lung? And so you need to sit them up a little bit. You need to recline them up a little bit so their belly is not pushing on their diaphragm. And the person coughing all the time, and the pressure is going against their cough. So you need to give them something for their cough. You need to paralyze their diaphragm. So the first thing you do, the easiest thing to do is just disconnect them. Just take them off the machine. And take a bag and just bag for them. And if you can bag them, and it's easy, then it's not the man, it's the machine. Right? No, this is easy. This isn't a problem. Then it's not the problems of the person. The problem is your machine. You got to look at your machine. If you do this and you're like, oh, you're stepping on the bag, then it's probably the man. You probably need to fix the person. You need to give them bronchodilators. You need to suction the person out, see if there's a clog down there, if there's a big mucus plug. You need to do something about the man. You need to paralyze them more, do something about that. Okay? So that's the easy way to solve it. Just disconnect them. Take the machine out and look at the man.
So if it's easy, it's the machine.
Yeah. Because if you're getting a high pressure alarm from the machine, but then you bag them and you're like, oh, this is easy. It's the machine. There's something wrong with the settings of the machine. And that's just what this is. Okay. So you've got them set up, the machine is running perfectly, and now you're going to figure out how to stop all this. You're going to figure out what stops the flow of air. Well, we talked about having a volume mode. You can either set the volume to a certain volume or to a certain pressure. And you can make a combination of these two. It's very simple. This is what terminates the mode. And again, most of the time we're going to set a volume of air. We're going to talk about why this isn't always good right now. Nope, we're not going to talk about it right now. I opened the wrong one still, but I changed this. Okay. Let's talk about this real quick. Okay. This is where it gets. Okay. So let's talk about complications real quick. So let's make it much more Let you stick. So you got a 35-year-old guy, history of asthma. He's got environmental allergies. He's on his 5th day of an asthma attack. He's been using his inhaler for the past 5 days. And now he's using it every 2 hours with very little. He comes in, he's a little hypertensive, he's a little tachycardic, he's a little tachypnic, he's a little hypoxic. When you put him on 4 liters of nasal cannula, he gets a little better, 95%. And he's just barely febrile, 38 degrees, which is 30 degrees is what? 100.4, perfect. Which is the definition of fever, right? 100.4. So you look at him, you get this well-developed, well-nourished male, slightly ill in respiratory distress. He's tripoding, right? He's leaning over. He's using all his accessory muscles. These short little staccato sentences, like barely breathe. Essentially breathless. Cardiovascular, he's tacky, but no murmurs, rotary gallops. His chest is greatly diminished, breath sounds in all fields. He's got almost no wheezing, no rales or rhonchi, and he's a little dusky peripherally, but no real cyanosis or clubbing or edema. So basically, what's wrong with him? So what is this called? Anything worse than that? Anything better than that? More exact diagnosis?
Respiratory acidosis?
Probable. We'll get lab and see, but what else? I'm going to
Lung
pretty much
infection.
guess yes. What? What's your name for this?
Respiratory distress.
Definitely. What else? He's on 5 days of asthma.
Acute respiratory distress.
It's refractory to his MDI now. Status asthmaticus. Okay. He's in status asthmaticus, right? He's having an asthma exacerbation that's refractory to his medication. Okay, status, you know what status epilepticus is? When you're having seizures that are refractory to your medication, you don't stop. So this is status asthmaticus. It's asthma exacerbation that is refractory or not treated with this medication. So he's essentially beyond just an exacerbation. That was maybe day 2 or 3. He's now refractory to his medication, okay? So this is status asthmaticus. This is a severe asthma exacerbation. He is in respiratory distress, close to respiratory failure, right? He's already tachycardic and tachypnic and hypoxic. So he meets definitions of respiratory failure, respiratory distress, okay? So we have life-threatening asthma exacerbation, possibly lung infection. We can't say it doesn't have a PE or thorax. So what do we do? Have you done asthma at all?
No.
Oh, that's tomorrow? One day. Okay. So we're going to give him a duodev, right? That's albuterol and ibuprofen, which is an anticholinergic. We'll put an IV in him and give him steroids and some fluids. So he gets epinephrine also because he's so bad. I mean, he's completely refractory. You guys don't know about mag sulfate and ketamine, but we gave him mag sulfate, which is a bronchodilator, and ketamine.
Is that like a horse tranquilizer?
Most certainly. It's also one of my favorite drugs. It is a horse tranquilizer. It's a sedative. It's an anesthetic. It's also a bronchodilator. And we use it for intubation as a sedative. But it knocks you out, but it keeps your respiratory reflexes intact, so you can still breathe while we prepare to intubation. Okay. We place him on BiPAP, okay, to help him breathe. All right, so what are we going to do with this guy? Now that we've done all this and he's still refractory.
We're going to intubate and place one of it.
Okay, horrible idea. But we're going to have to. You never want to intubate asthmatics. Like, it's the worst thing ever. It scares me. I hate it. I don't want to do it. But I have to do it. Okay? Intubating asthmatics is a horrible idea, but sometimes you have to do it. Okay? So we're going to do that. Okay? So we're going to intubate this guy. We're going to put him on a vent. What settings are we going to use then? What do you think we're going to put him on? What? Definitely. So what do you want to put him on? Like what major setting? Are we going to let him breathe, or are we going to breathe? You want him on SIMV?
So why don't we want to put an asthmatic on an ventilator?
We're going to talk about that.
Put him in a way while we don't want to.
Okay. So he's intubated, placed on a vent. He's paralyzed, completely paralyzed. We paralyze him. We don't let him breathe. We put him on AC. Okay. He's already breathing really fast and using all of his muscles to do this. Okay. That takes a lot of energy. He's probably been doing it for 5 days. That takes a lot of work. And he's breathing at 20, 30 times a minute. To do that on SIMV, that's a lot of work. Okay. So we're going to take that away from him, and we're going to help him breathe for a little while at least. We're just going to paralyze him. We're going to take his respiratory muscles out of it and give him a rest for a little bit. And we're going to breathe for him. Now here's the problem. There's something called breath stacking, or auto-peeping. Okay? And this is what this shows here. What's the problem in asthma? They get bronchoconstriction, right? And they get, if you listen to somebody, it's right? It takes a long time to get the breath out because of the bronchoconstriction. If we do the regular breathing, what's going to happen is I'm going to give them a breath, and before they can get rid of the next breath, I'm going to give them another breath. So this is what's going to happen. I'm going to give them a breath. They're going to exhale a little bit. They're not going to get it out. I'm going to give them another breath. Before they can get it out, I'm going to give another breath. Before they can get it out, I'm going to give another breath. And before long, their lungs are going to be overly distended. They're going to have what's called auto-peep, or breath stacking. They're going to stack one breath on top of the next, on top of the next. And that's going to cause a pneumothorax. They're actually going to blow their lung out. Okay? So you have to give them time to exhale. And this is, so you're going to have a prolonged I to E ratio, a longer exhalation than inhalation. So there's a very short inhalation and a prolonged exhalation. So if you want to kill an asthmatic, you intubate them, and then just breathe regularly for them. And this has happened to almost everybody in the emergency department at least once. I almost guarantee you. Happened to me, happened to all my colleagues, happened to everybody I've ever known. So they've intubated an asthmatic, and they turn their back to go write the note, and the patient arrests. It almost always happens. Happens for a couple reasons. If you're lucky, they don't get a pneumothorax. They just arrest. I know that doesn't sound great, but so we talked about it before. What happens when you get too much pressure in your lungs? Correct. If you're lucky, that's all that happens. You don't pop a lung. So as the lungs get full, see, this is good. What I wanted, okay, so vena cava, heart, right? The vena cava gets shut off, and you can't return blood flow because the lungs are over distended. I'm going to draw better lungs than that. Square. The vena cava gets shut off and can't return blood flow. So as these lungs get really large, the intrathoracic pressure builds up, and the blood flow gets cut off. They go into shock. So they drop their blood pressure to nothing. And they go into shock and they arrest. This happens due to auto-peep or breath stacking. So there's a tremendous way to look like a hero, even though you caused this. You don't look like a hero. You disconnect it from the vent. You pull the tube, you pull the machine off, you pull the vent off, and then you push on their chest. You literally just push on their chest. And you have this like literally a minute-long exhalation. They just go, and they exhale forever. And the lungs go down, and all of a sudden blood returns to their heart, and it circulates, and they all of a sudden get a pulse back, and they're fine. And it's like a miracle, like Lazarus. And even though you did this, you're like a hero. So everybody I've ever known has killed at least one asthmatic by doing this. Because you turn your back, you don't think about it, you leave, you set them at a rate, you set them at a low pressure, you set them at a normal respiratory rate, and they breath stack on you. And you don't, it just happens. You've got to be super careful. So, if you're unlucky, they get a pneumothorax, and they pop along, and that's harder because they didn't put a chest tube in. So this is called breath stacking. And that's what happens, is they don't have time to fully exhale and come back down. So what you want is to inhale, come all the way back down, and then inhale, and come all the way back down. And what happens is they're getting breath stacking. Is they're getting one breath on top of another before they fully exhale the next breath. That causes increased intrathoracic pressure, decreased venous return, and essentially and eventually shock. And the way to do that, the way to fix it is you just disconnect them from the vent, push on the chest to get complete exhalation, and all of a sudden they get a return back. And it happens like that. I mean, immediately they come back. If you're unlucky, they get a pneumothorax, and that's harder to treat. When you have an asthmatic with a pneumothorax, it's really hard because now they have one good lung, one drop lung, and you're putting a chest tube in, and it's really yucky. So, better to let them be a little hypercapnic, be a little under-respirated, than to cause an arrest. And once you do it once, you almost panic and never do it again. You never leave the room when you intubate. That's why I hate intubating asthmatics.
Oh wait, so if you just don't leave the room, then you can kind of...
No, it's not like you ward off evil.
Yeah.
It's like when I sit at the bedside, that doesn't happen. It still happens. No, you just got to be like super careful. So what I do is I stand there and I literally, for the first 20 minutes, I keep checking pressures. Plateau pressure, peak pressure, plateau pressure, peak pressure. And if that plateau pressure goes 20, 30, 35, so I'm going up above this, and I keep going up above this, then I'm in trouble. And I have to lower my IE time. I have to give them more time to exhale. So I used to literally, the first time it happened, I put them on the vent, and I went and did my note. I typed my note up, I made my phone call, hey, I got a patient in the ICU, waiting for the doctor to call me back, an ICU bed, and the alarm goes off. And my nurse is screaming and yelling. I'm like, what happened? So now, I spend my first 10 or 15 minutes with the patient, checking the pressures, checking the pressure, checking the pressure, making sure they're not getting higher and higher. And if they are, I just spread the respirations out. I just get them a longer time to exhale, longer time to exhale. So, I'm just, yeah. Me being in there doesn't make it not happen. I just, yeah, I'm not some lucky talisman. I just pay more attention. Yeah.
So you spread the respirations out on the machine?
You can lower the tidal volume, that's one thing. So lower the volume going in is one thing, but more important is give them longer time to exhale. Give them quick inhalation and a shorter, it's called IE ratio, and it's a setting. And if you don't know how to do it, your respiratory therapist will. So, in New York, it was a small hospital. We only had 6 ER beds, so I was the only person there. It was me and a nurse, that's it. So I was a respiratory therapist and the pharmacist and everything else. You learn all these tricks yourself. So, but yeah, I mean, I just sit there now and just wait a little bit before I run off. Because a lot of times you'll put the tube in, you'll think you're the hero because you got the tube, and you'll run off. Your job's not done yet. So, yeah.
If the plateau pressure is increasing and then you increase the duration of expiration,
Yes.
will that correct by itself?
Quite often, yes.
Okay.
Yes, quite often, yeah. Sometimes you have to lower the tidal volume a little bit, from like 8 to 6 cc's, and that'll help. But usually just giving them more time to breathe out takes care of it. In an asthmatic. Yeah. In ARDS patient, it doesn't always, just because the lungs are so boggy that the expiration doesn't help. You got to lower the tidal volume. But in asthmatics, it usually just helps to give them more time to exhale and get that breath out. That plateau pressure is happening because you're building up here. So, yeah. So that's why I hate intubating asthmatics, and I try to avoid it. I use BiPAP or CPAP. And that's why, I mean, you talk to any ER person or any ICU person, and they'll agree with you that asthmatics are fraught. Whether it's pneumothorax or whether it's this breath stacking problem, it's just a really bad situation. It's hard to handle. So, all right, so let's go back. Let's look at another one. Oh, that's the last one.
Other than getting a past medical history of asthma and albuterol, what other significance within the vitals? Is there anything that you would have been able to tell that it was from their inhaler and not something else?
No. So one of the other scary things about this being status asthmaticus is that when you listen to them, you know they have asthma, when you listen to them, you don't hear wheezing. It's like horribly scary about an asthmatic.
Asthma, no wheezing.
Yeah, it means they're so clamped down, they're not moving enough air, right? You gotta be able to blow on a whistle to make it whistle. If you can't move enough air through those clamped down bronchioles, that's bad. So you give them a Duoneb or you give them albuterol, and they open up, they start wheezing more. I'm actually happy about that, right? And now you're moving some air. But when they're so clamped down, you're wheezing, you're like, oh, that's what this is gonna be a fight. Yeah. So I actually like to hear wheezing in my asthmatics. When you're so tight that you're not moving air and not wheezing, that's a bad sign. Yeah, you're close to getting intubated. Let's look at this 36-year-old who was brought in by ambulance. She was drowsy, mostly obtunded, minimal history. Roommate came home, found her on the floor. So her pressure's 155/90, a little hypertensive, a little tachycardic, but bradycyptic, so she's respiratory rate of 6. SpO2 of 88 at room air, 100% on a non-rebreather. And she's also just right on the edge of being febrile. So her pupils are midriotic and sluggish. Her skin and mucous membranes are moist to kind of dry. Her bowel sounds are decreased, almost absent. She kind of moves a little bit when you painfully stimulate her, but she's non-communicative. She'll barely move her extremities. There's no sign of emesis or incontinence. You give Narcan and nothing happens. Any thoughts on what this is? Any thoughts? Okay, overdose is a great idea. Why do you say overdose? Okay. What about the history?
What history?
What history? Yeah.
But you guys gave her Narcan, so
Yeah.
that should have theoretically
Reversed what?
An
An opiate overdose. Okay. Any other overdoses?
No, I got alcohol.
Alcohol? Anything else? Aspirin? Anything else? I'm glad that's all the drugs people use in Oklahoma. Any kind of street drug?
Heroin.
Have you guys done any time? Yeah, sure. Marijuana. All the K2s and synthetics. There's a new one going around Illinois right now. It's killing people, right? A new marijuana. It's killing people. Synthetic. You're disconnected? Okay. Have you done any tox at all? Toxidromes, anything? Okay. So this is an anticholinergic overdose. Yeah, this is you'll learn about blind as a bat, right? Mad as a hatter. Anyway, maybe mixed ingestion. Okay, so of course you got to think about other things, right? So acute hypoglycemia, whether she had a stroke, some kind of CNS infection like meningitis or encephalitis, whether she's got like NMS, if she's on something like some kind of antipsychotic or antidepressant, whether she took too many of those. Thyroid toxicity with her being tachycardic and tachypnic and hyperthyroid. No problem. Probably not opioid, she didn't respond to that. Could be meth, although she'd probably be a little more agitated than me. Okay, so it's probably anticholinergic, and I'll tell you it was. She took an entire bottle of Bilateral. When her roommate left at lunch, her roommate found her 4 hours later, when she came home later. All right, so what do you want to do with this lady? Do you guys know the treatment for anticholinergic overdose?
No.
Don't worry about it, doesn't matter. We never use it anyway. Physostigmine, don't worry about it. Don't give it, doesn't matter. The best treatment for anticholinergic overdose is supportive. So what does she need right now? Fluids and protect her airway, right? So she's respiring 6 times a minute, and she's hypoxic with that, and she doesn't really move, right? And she is pretty much obtunded. So the worry is vomiting and aspirating. The worry is that she's going to become more hypoxic and she's going to go downhill from here and become more hypoxic and stop breathing. So she needs protection. Okay. So what's the best thing to do with her? Okay, so she is a really good candidate for SIMV. Right now she's breathing on her own. We can set it like 12 times a minute, right? So if she breathes, that's fine. She'll get a breath, a little extra support. And if she doesn't breathe, the machine will breathe for her. Okay, she needs her airway protected. She's got the muscles to do it. Her airway is fine. Her alveoli and her airway is fine. It's respirating and oxygenating is fine. It's just that we need to make sure that she keeps breathing for right now. So SIMV is fine. This will help her get over the hump. Okay, so we'll sedate her a little bit, put a tube in her, and then let the machine help her breathe until she gets over the hump. Okay? We don't have to take over control, we don't have to paralyze her. And in fact, we don't want to paralyze her, we can help it because we want to know when she's waking up and getting over this. The sooner she can get out of the ICU, the sooner she can get out of the bed, that's better. We don't want to keep her paralyzed, all the problems that comes with it. Okay? And yet we don't want to get her on pressure support where she's not breathing at all in case she stops breathing. Right? Okay. So that's pretty easy. All right. 22-year-old working in the field. He's stung by something. He has a history of a Hymenoptera allergy. What are Hymenoptera? What are Hymenoptera? What? And it's the largest class of insects. Bees, ants, wasps, hornets, all those things.
That little hornet and the wasp was the same thing.
Okay. He's always had mild reactions. Now, he presents, after 20 minutes of being stung, he begins to feel a little dizzy and has a little urticarial rash. He drives himself to the ED. Solid idea. So he gets here about 35 minutes later. He's very dizzy, lightheaded, and he feels like he's going to pass out. His voice is kind of like hoarse. And he says, my throat itches and my tongue feels swollen. Okay? His blood pressure is 80 over 60. Heart rate's 120. He's respiring 24 times a minute. His oxygen is 97, which is fine. His temp is 36.8, which is good. He's clammy, and he has numerous diffuse, ill-defined erythematous urticarial wheals. His voice is hoarse, almost stridorous. His pupils are brisk. He's tacky with no murmurs, rubs, or gallops. His lungs are clear. His auscultation bilaterally, anterior, posterior. His abdomen is non-tender, non-ascendant, with slightly decreased bowel sounds. Okay, what's wrong with this guy? This is anaphylaxis, right? He's got skin involvement with other systemic signs. Yeah, he's hypotensive, he's tachycardic, he's near crashing. What does he need? Epi, right? The only treatment for anaphylaxis is epi, right? It's not Benadryl or salbutamol, it's epi. What else does he need? Yeah, we need to make sure he's already losing his airway, right? So we are ready to intervene if we need to, okay? So anaphylaxis due to Hymenoptera sting. So think of other things, right? Was he out in the field with something? All right, so we give him IM epi. Where do we give it? IM, right? Not sub-Q, not IV. IM where? Anteromedial thigh, right? There's evidence that that's absorbed better and faster than anywhere else. So always in the anterior lateral thigh. Okay, and my nurses are rushing to get an IV in this guy. We give him Benadryl IM also. Then we start giving some fluids and some steroids. And what's famotidine? Yeah. It's an antihistamine for your stomach, so it's an H2 blocker. So you have some peripheral histamine receptors, H2. You have H1 and H2 in your skin. It's very few, but you have some H2, so we want to block all the histamine response we can. We give them H1 and H2 blockers, Pepsid. And everybody goes, what? My stomach's fine. And I go, I know. All right, so he's unchanged. So then we start giving IV epi, which you can do, anaphylaxis. We start giving him a drip, an IV drip, and we get set up for intubation. And we intubate him with paralysis and sedation, with the video scope, because it's a tough one. He's all swollen and edematous. His goes fine. I don't have to cut his neck open. All right, so what are we going to put him on?
The machine breathes for him.
Okay? We start off with that, definitely, because we just paralyzed him and sedated him, so the machine starts breathing for him, but hopefully what? And move him over to, yeah, either one, right? SIMV or pressure control. Because we're just doing this to protect his airway. He was breathing fine. He was breathing fast. He was 24 times a minute. So he was breathing fine, he just was losing his airway. So once the paralytics wear off, which is not long, if you give him succinylcholine, that's 8 minutes. He's paralyzed for 8 minutes. He starts waking up, he can breathe on his own, he's just going to have a tube in his throat. So we put him on SIMV or pressure control, either one. So start with AC when paralytics wear off. Once patients awake, they can breathe on their own. So pressure support, to keep pressure in the lungs constant and support his breathing. So he's wide awake, he can breathe, just don't want to make sure he doesn't lose his airway. And so he'll be fine. And while that epi drip is going, while he recovers from his anaphylaxis, he'll have a tube in his throat, and we'll take it out as soon as his wheels are gone, as soon as his throat's done swelling. And he'll be fine. He'll go home. With an EpiPen. And instructions not to drive. All right, this is a good one. So, 78-year-old female, diabetic, hypertensive, hyperglycemia, COPD. She's had 4 days of fever and chills. She's a little hypotensive, she's a little tachycardic, she's a little tachypnic, and she's a little bit hypoxic. When you put her on nasal cannula, she pops up 97%. And she is febrile. 39 degrees Celsius is what? Oh, come on. Close. Go. Like 101.6. So she's well developed, well nourished, in mild distress. She's got quickened deep respirations leading forward with pursed lips. We talked about that. She's tachy but no murmur gallops. Decreased overall breath sounds, scattered wheezes on both inspiration and expiration. She's got rhonchi on the right middle and upper, right middle and lower. And she's using subcostal and intercostal muscles. And she shows her supraclavicular muscles. She's not cyanotic, she's not clubbing, she's not edematous. All right, what's wrong with her? Definitely respiratory distress. Due to what? What else? Okay. Probably. Possibly, heading that way. Probably pneumonia. Why? Fever. Bronchi in the middle lobes, the right side. Yep. Okay. And so not only COPD, not only pneumonia, but what else does she meet criteria for? Sepsis. She's hypotensive, tachycardic, tachypnic, and she had a febrile, and she's got a source probably. So she's septic, and actually septic shock, because she's hypotensive. Okay. So working diagnosis of sepsis due to pneumonia, COPD exacerbation. She got some other things too. So we get her labs back. Her CBC comes back. She's got a nice leukocytosis at 23,000. What's normal? Do you know? 10 to 11,000. Yep. And you can even have a little bit higher than that, it's fine. And it's all segmental polys, like the not good kind. Kind you don't want. Yeah. Her chemistries come back. Her CO2 is 12. You got a little hyponatremia, hypochloremia, it's fine. Her GAP is 20. Her lactic acid is 5.2. What's normal for lactic acid? Okay, 1 to 2 is good. Anything over 2 is mild sepsis. Anything over 4 is severe sepsis. 5.2 is not good. Okay. Now, her ABG. What is her ABG show? Okay, primarily, what is her derangement? 7.11, acidosis. But her PaCO2 is PaCO2? Okay.
Respiratory alkalosis.
Shows a respiratory alkalosis. But, so that doesn't fit, right? So what's your primary derangement? With a,
Respiratory alkalosis.
correct. So she is a metabolic acidosis with a secondary respiratory alkalosis. Why does she have a metabolic acidosis? Because she's septic, right. So lactic acidosis is one problem, but she's also having a metabolic acidosis. I don't know, there's many reasons, mostly septic and all the buildup. So we're going to intubate her due to worsening acidosis and her respiratory fatigue, right? This poor woman is on her 4th day of breathing like this. She's 78 years old. How long do you think a 78-year-old can breathe 30 times a minute? And tack along at 120? And be hypoxic? She's already, okay, so here's what you gotta look at, right? So she's already acidotic at 7.1. What's normal? 7.35, 7.45, right? So she is breathing 24 times a minute, and she's not compensating yet, right? She's blowing off all of this carbon dioxide, and she's still not compensating. Her respiratory alkalosis hasn't brought her up yet. It still hasn't brought her up to normal. So all of this breathing, and she's still not normal. She's still acidotic. So how much longer do you think she can last? It's not long, I'll tell you that now. So we're going to intubate her because of worsening acidosis and her fatigue. So what are we going to put her on? We're not going to let her work at all, right? AC. We're going to take the work of breathing away from her, give her a break. We're going to knock her out. Sedation, paralysis, we're going to take it away from her. All right, asthmatics, I hate intubating. I hate intubating these people too. And here's why. She is breathing 24 times a minute, and she is acidotic. Very acidotic, 7.11. The heart doesn't like to be acidotic. The body doesn't like to be acidotic. It actually tolerates alkalosis a little better than acidosis. You don't like to be acidotic. I'm going to intubate this person. Now, your respiratory therapist comes over, they bring those big machines, a fancy machine with bells and whistles and dials, and they don't like you touching it. They're like, doesn't matter how long you've worked on one, they don't like you touching it. And so, they set this ventilator up because most people breathe at 12 to 16 times a minute. That's what you breathe at, okay? And that's when it comes set up. It's like, when they set it up, it comes at 12 to 16 times a minute, and the tidal volume is like 500. That's like just default when it comes set up. When they hook the patient up, that's what it starts at. If I take this patient and I put her on that machine, at 12 to 16 respirations and 500 cc's per breath, what's going to happen to this young lady? Exactly. She's going to become even more acidotic. Because at 24 breaths a minute, she wasn't able to keep up. Even all of that, she wasn't blowing off the acid. Now I'm going to slow her way down, and she's going to breathe off less acid. She's going to breathe off less carbon dioxide. That carbon dioxide is going to build up and up and up, and she's going to become more acidotic. So this is a second way to get a clean kill in the ER. First, intubate asthmatics. Second, intubate an acidotic person and just put them at the regular settings. Clean kill and walk away. Clean kill, they'll never know. You have to match their respirations to their respirations when you put them on, because that's exactly right. They will become extremely acidotic extremely quickly. It doesn't take long. They went from 24 breaths a minute, and now you put them at 12, 14, 16. They will drop like a rock. That CO2 will go through the roof. And now you've got someone who's 6.8, 6.7, and the body does not tolerate that well. You can't give enough bicarb to get that back. Okay? So, be super careful about that. And you can do that. There's a lot of ways to do that. If you give somebody like this, she comes in, she goes, oh my God, I'm hurting so bad from coughing. You go, okay, sweetie, I'll give you something for the pain. What's morphine do? Yeah, it slows the respirations down. Now she's hypoventilating, and she gets super acidotic. And you got a clean kill on your record. That's good. They'll never know it was you. So, you've got to be super careful about these asthmatic patients, these sick patients, and their respiratory status, and checking that VBG or that ABG. They depend on what they're doing when they came in. Okay. So, all right, last one. Yes.
So as you're fixing ventilations, do you give bicarb with it, or will it fix the?
Boy, that's like the debate right now in critical care literature. Most people say it doesn't matter. They say that the bicarb is excreted so quickly from the kidneys that it doesn't matter. But there's a whole other group that says it's worth it. That you give them a couple amps of bicarb, you hang a bicarb drip, and it will help someone. And that is a huge debate right now of whether it helps or not. I'm of the opinion that I'll do something. I will do anything to help them. So I usually give them an amp or two of bicarb, and I'll hang a bicarb drip, and I'll pray that it helps. I don't know. I don't know. That is a huge debate right now. Does it help a critical care patient? I don't know. There's a bunch of studies.
If you put them on 24,
Yep.
what she showed or she came into, do you monitor that and just like
Oh,
lower
yeah.
her down? Until
Oh yeah,
she gets
so I get
back to flow?
ABGs every 10 to 15 minutes. And what I try and do is I try and turn up the PEEP, I try and turn up the tidal volume, and then I try and slowly turn down the respirations until I can get it down to about 20 or 18. And that might take hours. And as I'm giving them bicarb, and as I'm giving her everything else too. Yeah. Getting antibiotics started, giving them bronchodilators, all that stuff. Sometimes just getting their respiratory muscles out of the way, because remember, they have a lactic acidosis, and some of that is from just the overuse of the muscles and this anaerobic respiration and anaerobic use they're doing right now. So if I can stop them from using their muscles, that helps decrease the acidosis too. And get the fluids. All right, last one. This is a kid I saw January, 13-year-old male with fever and chills for a couple days. Went in to see the urgent care clinic in town. They diagnosed with influenza A by a rapid influenza test. Given oral Tamiflu about 2 o'clock, I think. He'd already been vomiting for a couple of days and took the Tamiflu, kept vomiting all night. Mom came in at 4 o'clock in the morning because he'd been vomiting all day and he wasn't acting right. He kept having a fever and he wasn't breathing right. And she said he's just been out of it and not even answering her questions right. Okay, 13-year-old, fever, chills. Okay, 13-year-old who looks ill. He's kind of gaunt. He's kind of rotunded. Port turgor, dry mucous membranes, eyes kind of sunken, lips are chapped, tongue is cracked. Cap refills like 5 seconds. He's tacky. He's tachypnic, but his lungs are clear. His abdomen is kind of scaphoid. He's real thin, but he's got a benign abdomen. His neuro, he's really out of it. He opens his eyes when you kind of talk to him and rub him, and he kind of moves around, but that's it. He's a 13-year-old kid, 100/63, tachy at 135, tachypnic at 30, 100% room air, and he's afebrile right now. What's going on with this kid? He's shocky. What else?
Dehydrated.
Dehydrated. Desperately dehydrated. What else? It's a little hypothermic, actually. Okay. Oh! All right. So we get some labs back. White count's 11, white count's 12. HH are normal. Sodium's 138, potassium 3.7, chloride. CO2 is 4. BUN's 14, creatinine's 0.6, glucose is 458. GAP is 40. What's going on with this kid? He's in DKA. He's an undiagnosed type 1 diabetic who caught the flu. Mom said, oh yeah, you've been losing weight since Thanksgiving. He's lost like 42 pounds since Thanksgiving. I'm like, what? 42 pounds? You didn't think about it. So I made an appointment for like next week. I was going to get checked out. I'm like, 42 pounds since Thanksgiving. No wonder this kid's got like this abdomen that like caves in. 42 pounds since Thanksgiving at 13-year-old.
Wait, how much later is this though?
January.
This is January. This is the end of January. The very end of January, like January 30th. So. Like, you're kidding me. You're You're gonna make an appointment for next week to get him checked out. 42 pounds didn't bother you. So then he got the flu, right? Then he got really sick with the flu. So here's his ABG. pH of 6.8. CO2 20, CO2 47. Bicarb of 4. What's a basic CIS?
Is it like 21.8?
No, 2. Normal is 2 to negative 2. What does it represent? How much he's off. How much base he would need to get him back to a normal pH. And if you had to give him bicarb, how much you would have to give him to get him back to a normal pH. And again, a normal basic CIS is like 2 to negative 2. It's like 2 points either way. Negative 30. Okay. So he's diabetic, right? 438. That's the D. His ketones are 3+ in his urine. That's the K, diabetic keto. And he's acidotic, 6.84. Diabetic ketoacidosis, right? His kidneys are shutting down. He's throwing off granular cast, hyaline cast, fatty cast, essentially any cast that your body can make. He's throwing them off in his urine. His kidneys are completely shutting down. And he's obtunded, right? He doesn't answer me, he doesn't answer questions or anything. 13-year-old kid. 6.84. What does this kid need? He needs before insulin, actually. So here's the problem. What happens when I give insulin? A new mom. Her mom was actually really sweet. She was just not medically inclined at all, and not real with it. She had made an appointment for the next week, and she knew enough to bring him in that night. So I don't blame the mom completely. I blame the urgent care for missing this. The kid, he couldn't have looked great that afternoon, and they just said, "I got flu." So what if you give insulin? You know what happens? You notice what happened to any of these things?
Nothing.
No.
And so insulin, first of all, is going to make your potassium drop terribly. Insulin forces potassium into cells. 3.7 is already a little low. It's going to make it drop really bad, especially if this kid is dehydrated. And the other thing is it can cause, a lot of insulin can cause some cerebral edema also if you give him a lot of fluid and insulin. So he needs fluids badly. He needs a lot of fluids. Is the most important thing. And he needs judicious insulin. He needs a little bit of insulin, he does. But he needs it very slowly right now. What he needs an airway. He's obtunded, he's vomiting, like this is not a good situation. And he's super acidotic. And he's breathing 30 times a minute in a little kid. So he needs an airway also. So, oh, too bad. He got an airway, yeah, he got an airway. And he got put on AC control so that we breathe for him. And I think we put him on like 35 breaths a minute, really fast. And he still got more acidotic. And we gave him a bicarb drip, and I mean, he was sick. We flew him to Children's. He was sick. One of the sickest kids we've seen in years.
And he lived.
Welcome to the emergency room. I don't know what happens to anybody.
That happened to a girl here on campus last year. She was 20 years old, undiagnosed diabetic, and went into DK in the dorms.
Oh, yeah.
It was bad.
Yeah. Yeah. So, yeah, so AC, right? We take over all breathing for him, and we jack up that rate. And even when we put him like 35, and he still got more acidotic on the first ABG. We did ABG 10 minutes later, and he was more acidotic. He was like 6.79 right after that. Even with fluids and a high respiratory rate, he still got more acidotic. So, like I'm saying, you've got to be careful when you're taking care of acidotic people that you don't make them more acidotic. All right, quick questions about the ventilator. It's not hard, it's bellows. Right? You just breathe. Breathe. Yeah.
So the last lady that was at 24, we matched hers. Could we increase hers?
Sure.
As well?
Yes, and you can. So remember, there's two ways to do it. You either increase the tidal volume, so she's breathing more of it, or you increase the rate. Either one. And yes, eventually you're gonna do that, yeah. So she was breathing 24 times a minute, but not effectively. So she was breathing those tripoding short 24 times a minute. So by matching her at 24 times a minute, but giving her a good tidal volume, it helps. 24 effective ventilations is better than 24 cruddy ventilations. So usually that takes care of it. He had 30 good ventilations. So putting him on 35 good ventilations still didn't take care of it. we still had to go up. So, yeah, you have to look at how good their ventilations were beforehand, and then what's your matching. So her 24 cruddy ones, well, putting her on 24 good ones took care of it. His 30 were pretty good. He's a young kid, so he's still really puffing. Putting him on 30, 35 still wasn't enough. So, yeah. So I guess not just matching rate, but matching their ventilations, whether it's 30 good ones or 24 crappy ones.
Is there a risk of oxygen toxicity when you're increasing the time?
Sure. So oxygen toxicity. So you get an ABG, you put a person on. That's important to talk about real quick. We don't want to super oxygenate people. So when you get your first aid, you put a person on an event, you turn off the FiO2, right? We usually turn FiO2 to 100%. That's the inhaled fraction of oxygen. It's what's coming out of the wall into their lungs, 100%. And that's what we start with, because they're not doing good on 21%. So we put 100% on. And then you get an ABG, and it comes back, and you look at their SaO2, their oxygen in their blood, and it comes back at like 300. You're like, oops, kind of overshot that one. Yeah, and you don't want to do that. So what we typically do is, well, you want to get that in 80 to 100%, right? And that's ideal, 80 to 100%. We talked about earlier in ART, if you can keep the person at 88 to 92%, you're doing great. That's fine. Same thing when you put a person on a ventilator. So we put them on a ventilator, we jack them up, they get up to 100%, they're on 100% FiO2. And the easiest way to do it, you get the ABG back and you're like, oh my God, that's way too high. The easiest way to do it is just turn the FiO2 down until their oxygen goes down. Until they drop their SpO2, it's on the monitor. So also they drop and then they're 98%. Well now, you're fine. So now they're at 60% FiO2 or 40% FiO2, you're fine. They don't need to be at 100% FiO2 or SpO2. Turn that down. Turn that FiO2 down until their oxygen begins to drop. They don't have to be at 100%. You don't want them at 100%. Turn that FiO2 down as soon as you can so they're not getting hyperoxygenated. It is toxicity. It does cause some real problems. Yes. So turn that FiO2 down as soon as you can. Anything else?
No, but I have a different question. So for your wilderness medicine, so are you like negative and afraid medicine people?
I sure try not to be.
Bear Grylls, like what do you do? Like do you like go to the Appalachian Mountain? Like,
Yeah. We actually have a class out there every year, a couple classes every year. Yeah, so it's WMS, Wilderness Medical Society. We've been around for almost 40 years now. We started by some guys out in California at Stanford. And they're still around doing it. And so it's a huge group now, but we've kind of split off into different areas now. Everything from ocean medicine, dive medicine, there's a group that does that. There's religion in that. There's high altitude medicine. So we have a group that goes to Nepal every year and runs the Camp Everest, or the high altitude camp on Everest. Luann Freer, one of my friends, does that. She's the director up there at they do a yearly camp on Everest. It's mostly for the porters, mostly for the Nepalese people, for the Sherpas. Take care of them on Everest. We set up a school up there a couple of years ago for the Nepalese. So there's a group that does high altitude medicine. We bring in speakers from all around the world. We work with them on high altitude medicine. So HACE and HAPE and AMS, the high altitude medicine stuff. There's a group that does wilderness medicine. So we're talking about expedition medicine, like hiking and backpacking and stuff like that. So we look at, we do studies on, water purification and things like that. Every 6 months we put out a new guidelines. So guidelines on frostbite, guidelines on use of epinephrine in the backcountry, guidelines on, what else have we done? Like 20 guidelines out now. Lightning survival was the last one. All kinds of things like that. There's a group that does ski and ski injury. I mean, there's all different kinds. But yeah, we have 2 annual meetings, one in the winter and one in the summer. We get together. So I spent several months in Nigeria studying tropical disease and travel medicine. So we do, a group of us do travel medicine that do like consults if you're going to go overseas and work. Like what vaccines do you need? What antibiotics should you take with you? What's endemic to that area? Those kind of things. group of us that lead expeditions like whitewater rafting down the Grand Canyon and things like that. So, all kinds of things. WMS.org is the website. And there's a group of us, about 300 of us that have done a fellowship in it, 4 years of fellowship training in it. So we did a little bit of all of it together. So I did a huge, for my capstone, I did a big presentation on ticks, because living in New York, we have a huge problem with ticks, Lyme disease and all that. So I did a project on ticks and lightning.
Where did you hear things lightning?
So I did it with WMS. So part of it was in Nigeria when I was doing tropical medicine. So I did a lot of studies on like leishmaniasis and TB and all that.
Do they still do that?
Oh
For
yeah,
instance?
yeah, we do all kinds of stuff. So, yeah. So I'm going up to Utah this summer to do our annual conference. I'm trying to have fun. Our conference is like half a day and then I stay for 20.
That's okay.
A lot of fun. And we have a lot of fun.
Do you
Yeah.
mind sending me your new one?
Not at all. Not at all. I'll give you my email address if you've got questions. Anything else?
Thank you. Dr. Tassie just said something saying Thursday, kind of in combination with the TB lecture, and then Professor Lovick-Watt is going to do it tomorrow, I think, at 1, is that right?
Well, that'll be research. I can help you out. Help you out.
Yeah, just kind of talking to me.
You're done for the night? Yeah.
You're never done.
No, I'm working.
Oh, that's good.
Just get ready over this. So you guys, what y'all study?
That's what I feel like I'm totally supposed
PBLs tomorrow morning and Friday morning. Thank you so much. So she is changing to tomorrow. She said just an hour and a half.
So that's not bad. Oh, that's not bad at all. A little bit. We have SPVL. I don't think it's that long. No, it's just other stuff. I know I forgot to worry about it. I thought I was supposed to know that. Okay, how is that coming today?
Excuse me. Sorry, I've been. How was it? Moving back here. It was weird. It was like, I had to look at the screen, I had to like almost lay down. But I did feel like I paid attention. Well, like, I was so close to like your room.
I feel that way.
Anyway, oh yeah.
Yeah, before the last recipe, I like got in and I felt blood testing. I was like,
hard, like having us over and over and you're cycle. I know. I'll probably do that. I don't that's like really hitting it hard. It's hard to stand it. Because it's not really a big whiteboard, right? Well, it's like for what? No idea. Okay, I was just trying to I'll just let you know. I don't think it will be. I don't know, but if it's the same whiteboard as it so like you're like one, you know, like you like say you can't really hear very well, like let me know and I can more for you. Yeah, that's what. Sorry.